second sessions, which is really interesting, is a new paradigm in management of chronic hepatitis B. Before I start the sessions, I would like to introduce my co-chairman, Professor Roswamati Mohammed. She is a professor in medicine at the University of Malaya. And I think actually she doesn't need any introduction. We know her very well. So I would like to inform you a little bit. We will a little bit change in the program because Professor Sengchilim had to leave very early because he had a big business to do in Singapore. So we will start from Professor Sengchilim first. Professor Sengchilim is also a very well-known hepatologist, not only in our region and everywhere. He done a lot of publication on hepatitis B, and he's a professor at the University of Singapore. He will touch on the long-term and stopping role in the management of nuke therapy in patients with chronic hepatitis B. Professor Lim, please.
Thank you, Professor Thiravisud. And I'd like to thank him and Professor Tan Wan Di and the organizing committee for inviting me to wonderful Chiang Mai again. It's been a fantastic conference, and I strongly urge him to continue APLD next year. But of course, in between then, you need some extra conferences, such as the Singapore Hepatitis Conference. So please do come to it because it's only $150 registration fee. And I would also like to confirm the preceptorship program where younger doctors and trainees can get fully paid hotel, flights, registration, and you have to prepare one difficult to manage of hepatitis B or C case. Please go to the website and apply. There have already 22 people who've applied for this. We have 50 places for the preceptorship. So Thai doctors are very welcome to come to Singapore for a nice treat. You have a nice holiday when be fed with lots of good information. And many of the faculty today you see will also be there again. And of course, these are the faculty. Some of them you recognize. And some of the topics that are going to be covered, both hepatitis B and hepatitis C. So, of course, I better go and get on with my talk. Long-term nuke therapy and stopping rule in the management of nucleoside therapy. My disclosures, and I just want to discuss what I presented early on 2 days ago during the postgraduate course, that the paradigm is now moving towards S loss or eradication. A functional cure is S loss or seroconversion, and the possibility of absolute complete cure is the absence of cccDNA in the body, which is kind of difficult to achieve. So I think most people would agree that functional loss is a good target for us to aim for the future. And this is associated with very good outcomes, reduction in HCC and improved survival in this very large study from Korea, over 5,000 patients with a propensity score matching system. So the benefits of S0 clearance, I don't need to tell you, are reduction in liver failure, HCC, improved survival, decreased levels of cccDNA, and pretty much as close to a cure as we can achieve in chronic hepatitis B. So how are we going to manage this? Well, first of all, we need to select the cases at risk of disease progression and treat those, because not everyone progresses, and then decide which treatment. So obviously today I'm going to talk to you about nucleoside analogs and how to use them in the long term and maybe even stop them. I think Professor Henry Chan is going to talk to you more about interferon and the use in combination. But we know that there's some excellent nucleoside analogs available, especially entecavir and tenofovir, which have been approved by the guidelines due to their high genetic barrier and their safety profile. Of course, these treatments have quite predictable outcomes. I've discussed that with you during the postgraduate course. The nukes give excellent virus suppression, while immunomodulators, the virus suppression is suboptimal. but you get better E seroconversion in the immunomodulators than nucleoside analogs, and you get better S antigen loss, although one would argue that that's only marginal in terms of its benefit. So the current HBV strategy is something like this. For people who are treatment eligible, you start off with either a fixed duration interferon therapy. Of course, you have to appreciate that those with decompensated cirrhosis and acute or chronic liver failure are not suitable for this regimen, while nucleoside analogs are suitable for everybody. And they can be used in the short term if you achieve E antigen seroconversion. But if you don't, then you end up being on long-term nucleoside analogs, and you want to wait for S0 clearance. And I think here, during the course of treatment, we need to monitor for progress. And I just want to highlight that after E antigen seroconversion, we should monitor the possibility of them losing S antigen through quantitative S antigen, which is a new tool that we have today to monitor progress of our patients. And that, I'm going to show you later, raises the possibility that these patients might actually have S loss. So with nucleoside analog therapy, I think you've seen these slides before, that with each year of progressive treatment, there's increasing E antigen seroconversion. These are not head-to-head studies, but you can see that the trend is similar whether you use lamivudine, adifovir, entecavir, telbivudine, or tenofovir. However, as you have appreciated over the years, that the use of high genetic barrier drugs is much preferred because of the lack of resistance. You can see here that lamivudine and adifovir and tenofovir leads to quite high rates of drug resistance. Hence, therapy needs to be changed in them. And the guidelines now only recommend tenofovir and entecavir as first-line therapy. But are all nukes the same? I think this is a very interesting study that compares telbivudine versus entecavir in E antigen positive patients. And you can see that in these 4 meta-analyses that were done, the efficacy of telbivudine is comparable to entecavir in terms of reduction of viral load. However, when we looked at E antigen seroconversion, we can see here the pooled estimate of efficacy of telbivudine is superior to entecavir with a risk ratio of 0.54, which approximately is twice as good as entecavir in terms of E antigen seroconversion. So this is quite a useful strategy to try and induce short-term antiviral therapy so you can achieve E antigen seroconversion. Now, the use of telbivudine seems to be rather intriguing because it doesn't seem to behave just like a normal nuke, because when we look at this roadmap study that's done by Professor Piravisut here, published in PLOS S1 a couple of years ago, all patients were started on telbivudine, but those who had detectable HBV DNA at week 24 had add-on tenofovir. And you can see that by the week 48, both groups had equal viral suppression. But what is most interesting here is S antigen seroclearance at week 52 and week 104, you can see is 6 and 7%. So this is very intriguing that the combination of these two drugs could have led to an increase in S antigen seroclearance. After 2 years, these levels of S antigen seroclearance are very unusual for nucleoside analogs, because I'm going to show you some data on long-term therapy subsequently that the S seroclearance rates for other nucleoside analogs are significantly lower. Of course, most other patients who don't achieve S seroclearance have to go on to long-term therapy, and there's absolutely nothing wrong with that, because all the data shows that if you have these patients on long-term therapy, there's progressive suppression of HBV DNA in the long term. Both for entecavir and tenofovir, 99% of patients are virally suppressed, even in those with high viral load. And there's a possibility that if your patient has liver cirrhosis or advanced fibrosis, they would even have regression of cirrhosis in a significant proportion of patients. As I indicated before, that combination of talbivudin and tenofovir is very intriguing because if you look at the largest study, which I had shown you earlier, more than 5,000 Korean patients treated with lamivudine and entecavir at 6 years, the S0 clearance rate is only 2%. So clearly, to achieve a 6 or 7% after 1 or 2 years is quite remarkable. What are the predictors for S0 clearance from this study? Well, in orange are the negative predictors, and there's only one positive predictor here. At baseline, the ALT was 5 times upper limit of normal. But if you're E antigen positive, or you have a high viral load, or you have liver cirrhosis, the chance is that you're not likely to lose S antigen in the long term. The other question is, what is better, S loss or S seroconversion? So in this study, they've showed that S0 conversion is a protector against S seroreversion, where the S antigen returns. And they suggest that, in fact, a better definition of S clearance is persistently S loss with undetectable HV DNA after 1 year. So we need now to refine our definitions of S antigen loss, not only to include seroconversion, but also undetectable DNA, because we know that hepatitis B can exist in an occult form where there's low levels of detectable HBV DNA, even though S antigen is negative. What about the use of quantitative S antigen during nucleoside analog therapy? Well, this study from Patrick Marcellet looking at a tenofovir long-term study, these are the different genotypes here showing that, in fact, contrary to belief that the best suppression actually, the best reduction in quantitative S antigen comes in genotype B and D. However, we do know that genotype A has the most patients S antigen loss, but you can see here two distinct patterns here. Most patients basically have a slow reduction in HBV DNA, most of it occurring during the first year, and then it plateaus off, and the general reduction is about half a log. But those who are good responders and lead to S loss, you can see the pattern is dramatically different. They actually have a significant reduction in the early phase of treatment. And this subsequently progressively reduces until they become negative. And in fact, in this study, the strongest predictors of S antigen loss with tenofovir was Caucasian. So it's too bad for Asians, I guess, genotype A and D in particular, and who have less than 4 years of infection. But even in Asians, if the S antigen decline is more than 1 log at week 24, the hazard ratio is 13.7, which is a very high chance of having S antigen loss. So this is quite useful to measure if you are starting patients on nucleoside analogs to determine if they are likely to lose S antigen. It's a bit like, I guess, the use of response in terms of interferon treatment. However, I think based on the numbers of patients, don't expect to see too many patients with this type of response. So finally, this intriguing possibility of stopping therapy, and I think it started off with this very, very interesting study from Professor Hatsianis from Greece. These were patients in the original Adefovir trial and who had stopped treatment and then followed up for 6 years. And what is interesting is that out of these 33 patients, 13 out of 33 actually had S antigen loss with a follow-up of 13 years. 18 out of 33 had a sustained response, and of those 33, 15% relapsed and required to restart antiviral therapy. And when he looked at his multivariate analysis, what were the predictors of S antigen loss? no previous interferon, which was also quite interesting because I thought that would have been a positive predictor. A high baseline ALT, very similar to what we saw with that Korean study. Lower baseline HBV DNA, high end of treatment ALT, and lower end of treatment quantitative S antigen. I would like to highlight here that this is the group that has S antigen loss. And you can see here that this is the 1,000 cutoff. See, most of the patients had less than 1,000 units of S antigen at the end of treatment. In another study, this is, I think, from Hong Kong, we looked at 775 E antigen seroconverters who are followed up after seroconversion. Approximately half of them were on antiviral therapy. And we can see here they found that quantitative S antigen of 750 IU per mil or less led to a 33% possibility of S antigen loss over a 15-year period. And when they look at the AUROC, the predictor was 0.74, which is not very good, but it's not bad. So basically, S antigen level 1 year post E antigen seroconversion of 0.74 is a good predictor of future S antigen loss. In a separate study, I think this one's from Taiwan, they looked at E-positive patients and E-negative patients. And you can see here it's a little bit confusing because the S antigen levels are different. Here they use a cutoff of 300 for the E-positive patients, and that's led to about 80% of patients having S antigen loss. But for the E-negative patients, the S antigen level is lower, 120 IU per mil. So there's still some confusion about what is the right cutoff, and of course, needless to say, you are familiar with Professor Henry Chan's study sitting in front of me here, so I better present it properly. And he found that in a small group of E-negative chronic hepatitis B patients on lamivudine, and then they subsequently stopped lamivudine, they found that the S antigen at the end of treatment, it was less than 100 IU and had more than 1 log reduction. They had a 100% predictive value of losing S antigen. If they had less than 100 IU per mil or greater than 1 log reduction, then they had a 50% chance. But if they had neither, then they had no chance of losing S antigen. And finally, I want to discuss this study which was presented by Thomas Berg and Easel recently. It was a randomized controlled trial, quite a small one. Chronic hepatitis B patients who are E antigen negative, more than 4 years on tenofovir therapy, and undetectable DNA for more than 3.5 years. They were randomized either to stop tenofovir or continue tenofovir, analyzed at week 48. And they did not have cirrhosis, had no history of decompensated liver disease, and they could restart tenofovir based on viral load, ALT, PT, and bilirubin. So out of 45 patients, 3 withdrew consent, so 21 were randomized to stop, 21 randomized to continue, and here are the results. So in the stopping treatment, what's interesting is that the S antigen levels actually decreased. Compared to those, if you can look at the log reduction in S antigen, you can see here those patients with S antigen loss had the biggest reductions in quantitative S antigen. And you can see here overall the reduction in S antigen is far greater in those who stopped treatment than those who continued treatment. The median was 0.088 in those who had continued treatment and 0.283 in those who stopped treatment. So this is the possibility that stopping treatment may actually allow the immune response to recognize the virus and start reacting against it. So the summary for this study is they concluded that stopping was safe. 86% of the patients have not restarted therapy by week 48, and it was stopping therapy was associated with a more profound decline in S antigen levels compared to continuous tenofovir treatment. And S antigen loss was observed in 2 subjects. Of course, it's a small study, and I think we need to confirm it in a larger study. But here's an intriguing question. Who are we supposed to stop treatment in the E-negative patients? We have a lot of data now on quantitative S antigen level. So Professor Hatziane's study, less than 1,000. Professor Henry Chan's study, less than 100, or greater than 1 log reduction. So we are still not sure at what point we should start considering stopping therapy. So to conclude, ladies and gentlemen, nucleoside analogs with high barrier to resistance are recommended as first-line therapy and can be used for a wide spectrum of chronic hepatitis B patients. Not all nucleoside analogs are similar, and some may behave differently, such as telpividine, which intriguingly seems to increase E seroconversion and S seroclearance. Long-term therapy needs to very predictable outcomes, as I've told you, with even improvement in fibrosis and cirrhosis. But the prospect of S-antigen seroclearance is quite low. You could possibly combine telvividine to enhance S-antigen loss, but we really need confirmation in larger studies. But now the possibility of stopping therapy can lead to S seroclearance, but only in those with low quantitative S-antigen. But how low is a question still to be answered and waiting for further studies. So thank you very much for your attention, and don't forget to apply for the preceptorship.
Thank you very much, Professor Lim, for the comprehensive overview on the management with NUC therapy. Since Professor Lim is going to leave, we invite questions now rather than after the third speaker. Is there any question you want to forward to Professor Lim on his topic?
Okay, Professor Tamandi, and followed by Professor Ledley.
I think it's just a quick question for I enjoy your talk. But for the S antigen quantification, so for the long-term treatment, how frequent you're going to measure surface antigen?
Good question. I mean, there's no studies. But
it might add the cost for the monitoring, but how frequent that you think that could be useful and balanced with the cost effectiveness?
I don't think there are any studies about how useful. I think they should be done at least once, definitely at baseline before you start, and probably at week 24, because that is a good predictor time point of response. After that, if you don't see more than 1 log reduction, then you might choose to monitor it once a year. In clinical practice, I guess that's still not very clear. I do it generally once a year so that I can give my patients some idea of what's going on. But obviously, if it's at 10,000, then you might want to choose to do it once in a while, right? Maybe once every 2 to 3 years. In fact, what I've been doing is that I do routinely test S antigen for most of my patients, but now I've replaced it with quantitative S because I think that's a more useful tool. Yes,
Raj. 2 questions. Unfortunately, some of us are not privileged to have this quantitative S antigen test.
You Americans are behind times.
So we have the best fighter jets and all, but no quantitative S antigen test. So is there a surrogate for that I can use, or is it reasonable in a non-cirrhotic to stop after 3.5 years or 4 years and see what happens? What are your thoughts?
Well, Apazil did recommend a stopping rule, DNA negative for 3 occasions, 6 months apart, has never been validated. And in fact, I think some of the studies that looked at that found that there was tremendously high rate of relapse. So it's probably not a good idea just to stop out of the blue. I think at this point in time, it's still not clinical practice. So we need a lot more data because we don't know what cutoff level. And we need to have confidence that when we're going to stop, in fact, it's not going to rebound. I think the Thomas Berg study, they didn't stratify by quantitative S antigen levels, but it's certainly intriguing that 86% of the patient remained with low levels of viral load. Well, I think, Americans are always slow to take up things. FibroScan has just been approved. Quantitative S antigen still to come. So, but the good news is that it's still not, incorporated in clinical practice at this time. We're still waiting for more data. So by the time the data comes, hopefully you'll have been approved in the US. And I don't think that's a surrogate.
Right. And so for E antigen positive, I may have missed it. So what do you do in a non-cirrhotic? What are the endpoints for stopping treatment in E-positive?
E-positive patients?
Yeah.
So I think e-antigen seroconversion is clearly the endpoint, and consolidation therapy of at least 1 year now. I think APALSA is now recommending 18 months in the new guidelines.
Only the non-cirrhotic, is that right?
Yes.
Okay, thank you. Can we thank Professor Lim?
Thank you very much.
Good. I will call upon the next speaker, who actually needs little introduction, Professor Henry Chen from the Chinese University, Hong Kong. He is actually, very briefly, the Assistant Dean, the Head of the Division of Gastroenterology and Hepatology, and Director of Institute of Digestive Disease, also the Director of Center for Liver Disease. And he's extensively has published, and we welcome him to give this lecture.
Thank you, Rose. Thank you very much. And I would like to thank the organizing committee for inviting me here to beautiful Chiang Mai. It's a very good way to start the conference schedule of a year in Chiang Mai. So following Singi's talk, I think this is actually a better arrangement so that I can follow Professor Lim's talk and talk about combination and switch therapy. As Professor Lim has enlightened us, we only have two classes of drugs that we can use right now. A PET interferon, which is extensively used in lots of places. I just learned in Italy, a third of patients are using it as a first-line treatment. It definitely is a beauty of a finite duration of treatment, higher sustainability of treatment, but still there are limitations of a limited response rate, side effects, and the need of subcutaneous administration. So lots of people are actually using nucleotide analogs because they're very potent, very few side effects, easy to use, once daily oral dosing. But we just learned that it is quite difficult to stop. Most patients require long-term treatment, and in old days, we are still facing drug resistance problem. And in Thailand, if lamivudine started as a first-line therapy, we may still face resistance problem. So lots of people are thinking about combination of switch treatment. Actually, this enthusiasm is not starting today, but it starts in very, very early days when we have interferon therapy. It's actually a logical partner to combine interferon with NA, but we need to know what do we want by combining them. Actually, if you want to combine interferon and NA, we are looking for higher off-treatment response rate and a less need of long-term treatment. There's no point to combine interferon and aim at a long-term, lifelong therapy because NA is good enough for that. But there is trade-off because once we combine these two, we increase the risk of side effects. The drug may interact. Each drug may have its own side effects. We inevitably increase the treatment cost. And because we aim for sustained duration of therapy, of course we will try to stop therapy. But once we stop therapy, there's a chance of relapse, and we have to consider retreatment for those who relapse. So this is the thinking behind when we talk about combination therapy. So starting the last decade, there are lots of studies, actually starting from the use of PET interferon and lamivudine, people combine. And a lot of studies already, very big studies, combine interferon with lamivudine and adafovir, either simultaneously on a staggered regimen. So either interferon first, lamivudine first, or starting both together. In general, the consensus is when we combine both drugs, the on-treatment DNA suppression is bigger in a combination therapy arm. But once we stop, the sustained off-treatment response rate is very comparable on a combination arm versus the interferon monotherapy arm. So right now, in most guidelines, combination therapy of interferon and NA is not recommended. So is it a class effect? Lots of people have debates. Oh, lamivudine has too much drug resistance. It's not potent enough. So the two drugs combined doesn't yield a better response. So this study from China actually hammer the nail on the coffin, almost. They combine PET interferon with entecavir, a drug which is a first-line NA therapy with very low drug resistance, very potent antiviral suppression. So the arm A is the control arm, PET mono, and arm B, they start PET first, and arm C, they start entecavir first. And the combination arm, entecavir was only used for half a year. And if you look at the results, there's actually no difference in ECU conversion rate and S loss rates among the 3 arms. So the authors concluded that combining entecavir with peg interferon will not improve the chance of sustained response. So is it a family effect? So are all news the same? So when I look into the paper, which is a incomplete study testing combination of peg interferon with terbinafine, one interesting phenomenon is on the combination arm, the probability of undetectable DNA, the extent of S decline are much, much bigger than either peg interferon monotherapy arm or the terbinafine arm. But this study was stopped prematurely because of very high drug-induced side effects. It's very high probability of peripheral neuropathy, and some of these patients were very debilitating. So this combination is not recommended at all and is contraindicated, but this study gives us some information that combining terbinafine with peg interferon may have a better immune clearance effect. Very recently, the paper of peg interferon plus tenofovir is published, actually published early this year. So this study has a testing arm of tenofovir plus peg interferon alpha 2A starting together for 48 weeks. And the 2 control arms, one of them is tenofovir monotherapy and other is peg interferon monotherapy. The green arm is an exploratory arm that only uses a very short duration of combination. Peg interferon will stop at week 16, and tenofovir will carry on till week 48. And these are both E positive, E negative patients. It's a global recruitment, so it involves patients with all genotypes. But mind you that none of these patients have bridging fibrosis or cirrhosis or biopsy, and all of them have a relatively low liver stiffness and fibroscan. So this is mainly for safety concern. And the interesting finding is a very high S loss rate, up to 9%, in a 1-year combination arm, and this is significantly higher than either exploratory arm, the PEG monotherapy arm, and for tenofovir monotherapy arm is actually 0% after 1 year of treatment. So this is one completed study with a big enough sample size suggesting that combining an NA with peg interferon can yield higher S loss rate. If we look into the S decline rate, is actually much faster and deeper with the 1-year combination arm, that is the yellow line, as compared with peg interferon monotherapy arm, the gray line. If you look at the green line, which is exploratory arm with a short combination, in the first 16 weeks, the green line overlaps with the yellow line. But once peg interferon is stopped, the line goes flat. So if you really want to have S decline, which is reflecting immune clearance of virus, we do need peg interferon therapy. And it seems that combining these two drugs can give a deeper and faster S decline. But 9% S loss is still too low. I cannot recommend you to use this regimen for all patients because 9% is too low. So in this study, we have tried to find some predictive factors for S loss. And in the 1-year combo arm, we found that if a patient has more than 1 log S decline in 12 weeks, which is very, very fast, then the specificity is 92% and the negative predictive value is 97% for S loss. In other words, for those patients, if you cannot achieve one log S decline in week 12, you can actually stop peg interferon, maybe at week 16, because you need some time to wait for the results. And this will be almost like the exploratory arm, and it's almost like peg interferon monotherapy. Then you do not need to treat all patients with 1 year combination therapy, but only with a 9% chance of S loss. But this is more a proof of concept study than a study that guides you how to use treatment, because this study only tests simultaneous combination. So how about staggering of treatment? Does the timing of combination matters? Because in the past, a lot of people say that we should start PEG first, we start NA first. So let's go to some basic data. So this is a study, I think it's a very elegant study on the first 2 weeks of treatment. So they compare 4 arms of study. Arm A is tenofovir monotherapy. Arm B is PEG plus tenofovir combination therapy. Arm C is a double dose of PEG interferon therapy, 360 microgram per week. And Arm 4, there's an Arm D, there's no treatment. They just look at the T cell reactivation in the first 2 weeks of therapy. And to read the graph on the right side, the green line you can only see on the PEG arms. In other words, tenofovir has no immune stimulation at least in the first 2 weeks of treatment. And if you look at the T cells, it's exactly identical to that of no treatment. Only for arms with interferon combination with tenofovir or PEG interferon monotherapy, you see T cell stimulation. But NA will also stimulate the immune system, but much later. So this is an older study on lamivudine, and there's only 12 cases of lamivudine-treated E-positive patient, and we found that after a dramatic reduction in HBV DNA, the T cells started to go up, and it also is accompanied by interferon gamma stimulation at somewhere around week 12 to week 24. So this is a one-off transient immune stimulation triggered not directly by the NA, but triggered by a rapid drop of HBV DNA induced by the NA. So this study, the European study, is very clever. So they try to make use of both, try to enjoy both immune stimulations. So they pick a group of E-positive common liver disease patients. All patients are treated with 24 weeks of entecavir. So hopefully by that time, the DNA has dropped low enough, and the NA-induced T cell stimulation is there, and then they randomize patients to either add on packages or just continue entecavir. So half a year later, PEG interferon stopped. And for those patients who achieve ECU conversion, that is the responders, they just use half a year more entecavir and they stop treatment. For those who cannot achieve ECU conversion, they just carry on. So this study is predominantly in Hep C and D HBV infected patient because it's a global multi-center study. So what they found was, for those patients who receive a half-year combination of PEG, the chance of ECU conversion was higher. The add-on group has 26% ECU conversion as compared to only 13% of ECU conversion in the monotherapy arm. But once they adjust the DNA level with 24, which is the time of randomization, they found the add-on was independent associated response. And in this study, response was defined as E loss plus an HBV DNA less than 200 IU per ml at week 96. That is after stopping therapy for those who have undergone ECU conversion. So this serves as some evidence that a staggering of treatment is helpful. But one drawback of this study is that there's no interferon monotherapy arm. So they compare with entecavir alone. So we still do need more evidence to show that the staggering is good. But the good thing is they only use half a year PEG, they do not need 1 year PEG. Well, there's one very brave study, actually published a few years ago, escaped the surveillance rate of most people because it's a small study, but I think very interesting, from Italy. It's from E-negative patient with DNA more than 2,000 IU per ml and elevated ALT. They randomized patient into either starting PEG interferon therapy for half a year and then switch to tabevudine because we're not allowed to combine. This peripheral neuropathy is too serious, but they're brave. They stop and switch. I dare not doing it. And the other arm is they start tabevudine first. After half a year, they switch to interferon. So all patients actually receive the same treatment. Just about the difference is just about the timing. And the interesting thing is that they found that for those patients who start tabevudine first and then PEG interferon, there is a significant higher rate of DNA less than 2,000 IU per ml half a year after stopping the drug. And numerically, there's also higher probability of detectable DNA and also higher probability of normal ALT level. So this illustrates that timing matters, and probably one should first enjoy the immune stimulation by the NA, by starting NA for some time, and then we add the PEG interferon and enjoy the second and third hits of immune stimulation rather than the other way around. So with this data, people start to think about, how about patient on long-term NA? So this paper, again in JHEP, published 2 years ago, they look in the 12 patients, but in detail about the HBV-specific CD8 and CD4 stimulation. And all these patients were on long-term NA is very heterogeneous. They may be on lamivudine, combination of lamivudine, tenofovir, combining entecavir with adavovir, so various combination of drugs. But these people have been on long-term NA, and they add on interferon, and they found that lots of patients have S-specific or core-specific CD8 and CD4 stimulation. So this illustrates one very important concept that we were wrong in the past, that patients with normal ALT should not be started with interferon, because at that time we are talking about immune tolerance patient. Now we are talking about immune active patient being treated by NA. So there are different groups of people, and this group of patients still have immune stimulation by interferon, even if their DNA is undetectable, even if the ALT is normal. So there's some small studies illustrate the same point. So this is again a very small study with only 10 patients on NA for at least 3 years. All of them have persistent undetectable DNA level, and the S level is actually on the relatively low side, ranging from 50 to 1,700. And they found after they switched to add on interferon for 1 or 2 years, they found S decline in 9 of 10 patients, 4 reached undetectable at week 48, 1 at 96, and 1 after end of treatment. In all 6 patients who have S loss, they remain undetectable S loss even after everything is stopped. And then it comes to the famous OSC study from China. They recruited E-positive patients on entecavir, and these patients must reach a undetectable DNA that is less than 1,000 copies per mil as defined by their lab, and also low E antigen titer. So they try to find some patients who have some evidence of immune clearance, although not yet as E loss, but at least E titer being lower than 100 pi per mil. And they randomize these patients either to switching the interferon with a 4 week of ETV overlap or continuation of entecavir therapy. So there is numerically a higher chance of E0 conversion in PAC alpha 2A group, 14.9% versus 6.1% in entecavir treated group. But the most important thing is the much higher chance of S loss. In interferon treated patient, 8.5% of patients actually lose surface antigen, 4.3% of them has S0 conversion, as compared to none of the patients in ETV group. But this percentage is still too low. This is somewhere around again the 9% S loss rate. I still can't ask everyone to switch their NA patients to PAC interferon because of this very low rate. So some other studies try to look into who will develop S loss. So this is actually a multi-center study presented at EASL half a year ago. It's actually a randomized control study among E patients who are E positive, who develop E loss this time. So not just a low E titer, the E loss with DNA less than 200 IU per mil while on NA for 1 to 3 years. They randomize these patients into either 1 year or 2 years of PAC interferon alpha therapy. So no patient will just continue the NA. So they presented the 1 year interim data. So in other words, 271 patients have all received 1 year of PAC. And they try to use this to estimate the predictive factor of S loss. 16% of patients in this group have S loss, a very, very high rate, respectable sample size, and they found patients with baseline SAG less than 1,500 had 33% of S loss. And if at week 24 after switch, if the S antigen dropped to less than 200, 48% have S loss. So now this is a much better number that we can use. Of course, I would like to see the full report of the study, including after stopping treatment with the S loss reverted back to S positive. But at least, I think we now know that for those patients on NA therapy, if they lost the antigen, DNA suppressed, S antigen low level, if you're really thinking of stopping treatment, if they can take interferon therapy with a reasonable safety profile, then this is something that you can think of, because 1/3 chance of S loss is nothing we have ever seen in hepatitis B therapy. So I think to combine NA and PAC is still a theoretical thing. I'm not saying that we should do it tomorrow back in our clinic, but at least we got a lot of good insight from what we learned in the past. Combining NA with entecavir or tenofovir might have additional viral suppression effects on E positive patient with high viral load. Combining PAC interferon and NA tenofovir is probably the best choice. And if we can see a significant S decline, this is in the gastro paper, more than 1 log decline at week 12, we can, for those who fail to achieve that, we can stop the PAC because not everyone will respond. But probably starting both drugs together may not be the best way. We can better start the PAC a little bit later, maybe more than 24 weeks after we start the NA. And for those long-term NA users, we still can promote S clearance among patients who have S loss if they're E positive to start with, and particularly good if these patients have a lower HbA1c level. So these rules, you may think about it in your future study, and I think they also give good insight in the development of new drugs. For example, for new immunomodulators or any new drugs targeting about on the different targets of the HBV life cycle. So the summer talk, I would welcome you if you go to Hong Kong to visit our beautiful campus at the Chinese University of Hong Kong. But remember, do not go the wrong way, because if you want to go to Hong Kong, University of China, you will go to another corner of the world. Thank you very much.
Thank you very much, Haley, for that very informative lecture. Now I would like to introduce the next speaker, Professor Mauricia Brunetto. She's a professor in medicine at the University Hospital of Pisa, and now she currently is the director of hepatology unit of the University Hospital of Pisa since 2001. I think Mauricia done a lot of publication. She published over 200 scientific papers and been cited over 8,400 times, and her index is very high, 47. So please join me to welcome Professor Brunetto. And she's going to give a talk on dashboard for personalized management of chronic HbA antigen carrier and chronic hepatitis B. Professor Brunetto, please.
Thank you, Professor Piravizzi, for the kind introduction, and thank you also to Professor Tawandi for the invitation. So I'm really happy to be here to talk on HBV management, patient and carrier of HBV management, and particularly because of the distinguished audience and the expertise in Asia on HBV, I think is high and increasing, and so I think it's very important to share the experience with different also epidemiological and virological situation as we have in, for instance, in the Mediterranean area. The interplay between the virus and the host is determining the outcome of chronic HBV infection and disease, and also some specific characteristic of the HBV virus influence the natural history. We have to keep in mind that HBV is not a cytopathic virus, so the virus may replicate in the hepatocytes without inducing liver damage. This may occur when the immune system is not specifically activated against the HBV in the so-called immunotolerance phase. But on the opposite, once the immune system has been activated and is able to control HBV replication, still the infection may persist in the liver, again without overt or active liver disease. Thus, if we will be able to look at the interplay between and at equilibrium between HBV and host immune response, we can identify the different phases of HBV infection. The immunotolerance phase, where the virus is replicating without major liver damage. The immunoclearance phase, where we have immune activation, but the immune system is unable to control HBV replication, and thus we have consistent liver HBV DNA replication and liver damage, and the immunocontrol phase, where the immune system control viral replication. But at the single patient level, to identify the phase of the infection and define the feature of the eventual liver disease, we should be able to look at the virus, at the host immune response and at the interplay between virus and host. At the moment, in clinical practice, we have only validated at clinical level some viral markers, nucleic acid markers, or antigen, HBV antigen detectable, whereas as far as it concerns the host immune response and the virus-host interplay, we have some potential interesting assay. They need to be validated at clinical level or even further implemented. In the recent year, at least in Europe and Asia, we use as quantitative and HBV DNA as combined markers to characterize our HBV carrier, and the combined use of the two markers is proved very useful because the information we obtain by the quantitation of the two are different. From HBV DNA detection, we are able to monitor viral replication, whereas as quantitative can give us information about the overall amount, but particularly in E-negative carrier, about the transcriptional activity of cccDNA. So it's a surrogate marker of the status of the infection in the liver. But if we want correctly use HBV DNA, we have to keep in mind that serum HBV DNA is a direct marker of HBV infection. We are using HBV DNA to identify occult HBV infection. Is a direct marker of viral replication, but serum HBV DNA cannot be a marker of HBV-induced liver damage in an E-positive carrier, because we know that in the immunotolerant phase, very high level of HBV DNA are present in absence of consistent and active HBV-induced liver disease. By contrast, in the case of E-negative anti-E-positive carrier, the persistence of significant level of replication, we may discuss whether above 2,000 or 20,000 international units, indeed is a hallmark of the presence of active replication and liver disease, because in the case of E-negative anti-E-positive carrier, the presence of anti-E is indicative of an activation, of a specific activation of the immune system against the viral infections. Finally, the identification of low level of HBV DNA at a single point of in a E-negative anti-E-positive carrier cannot be used as, cannot rule out, exclude the presence of chronic hepatitis because of the fluctuating profile of E-negative chronic hepatitis B. As far as it concerns as quantitation, several studies from Europe and Asia show as the level of HBsG decline with the transition from the immunotolerance to the immunocontrol phase, and that the lower are the serum level of S antigen, the higher is the control of HBV infection. However, we have to consider that when we are detecting S antigen, we are detecting a viral constituent, and in this sense, some characteristic of the virus, for instance, the HBV genotype, of the variability in the pre-SS region of HBV may influence directly, independently from the extent of the immune control produced by the host, the level of S antigen. Furthermore, as a portion of HBV DNA may integrate in the host genome, we may have production of S antigen from the integrated DNA fragments. So all these factors may influence S antigen level at the single patient level. And for instance, it has been shown, as indeed in vitro, that the different genotypes are producing different level of S antigen, and particularly genotype A produce higher level of S antigen as compared, for instance, to genotype D. This is are the in vitro data. In clinical practice, what we were able to show in E-negative patients, but it has been also shown in E-positive, in again the S antigen level are different according to the genotype, and also the kinetics of S antigen is different, for instance, during interferon therapy, but also during NUX therapy. This has been shown by Fabienne Zulim. And in the case of a negative patient during interferon, you can observe as the kinetics profile of S antigen according to response to therapy, response or non-response, are significantly different, both quantitatively but also temporally, in genotype A as compared to genotype D and B or C. Thus, indeed, when we are using quantitative S, we have to keep in mind that we have to know, to optimize this use, the infecting genotype. Another point is the heterogeneity in pre-S region. The S secretion is influenced by and depends on the proper stoic ratio between L and S protein, the large and the small S protein. In case of unbalancing between these different S protein, we may have the storage of S antigen in the liver without the secretion. Thus, we wanted to analyze whether the pre-S heterogeneity was able to influence the S level in a cohort of negative genotype D patients and HPV carrier. And what we show was that, first of all, the heterogeneity in the pre-S region was increasing with the progression from inactive carrier to chronic hepatitis and cirrhosis. And the other very interesting point is that mainly in cirrhotic patients, the presence of a mixed population with pre-S mutant was able to influence S antigen level, and cirrhotic with a mixed viral population implying pre-S mutant had lower level of S antigen as compared to those with wild type pre-S region virions. Thus, we may hypothesize that during the natural history of chronic HBV infection, we may have two conditions where the S antigen level are low. One is the case of an early and effective immune control, like the control that is achieved in inactive carrier. So in this case, we have low antigen level as expression of an effective immune control, but the opposite condition is the case of patients who maintain long-lasting immunoactivation. Thus, this determines a selection of a viral quasi-species with selection also of a pre-S mutant that could influence S antigen levels. Thus, low S antigen level have a good prognostic implication in the inactive carrier. That could be the negative carrier with low level of DNA and non-evidence at liver ultrasound or fibroscan of significant liver damage, but have a bad prognostic value in cirrhotic patients, because in this case, the viral quasi-species with pre-S mutant could be even indication, predictor of higher risk of the ACC development. Indeed, in clinical practice, we were able to show in our E-negative genotype D carrier that the combined detection of low S antigen level and HBV DNA at a single point was able to identify with high predictive value inactive carrier. Similar data were produced in genotype B and C infected carriers. But more recently, we follow a larger cohort of E-negative carrier. And as already Ferruccio anticipated, we follow this patient for 1 year to characterize precisely the phase of the infection. At the admission, all the patients had viremia below 20,000 international unit and normal ALT. Well, as you can see, after 1 year of follow-up, we had a proportion of patients with relapse, with evidence of liver disease. But the important and interesting point is that among those carriers who had at baseline viremia below 2,000 international unit, none of those carriers who had also S antigen below 1,000 develop evidence of hepatitis, suggesting that indeed the combined use of HBV DNA and S antigen at baseline may help us to identify carrier with very low level risks of reactivation. In the same cohort, we try to better to analyze the level of S antigen in our inactive carrier. And at variance with our previous work, we found that 31% of our inactive carrier had S antigen level higher than 1,000 international units, whereas in the previous study done only in genotype D patients, this occurred only in 9% of the cases. Well, in the multivariate analysis, it appears that the country of origin and the genotype were were associated with the presence of S antigen level higher than 1,000 international units, even in inactive carrier, thus suggesting that, again, at the single patient level, we have always to make an interpretation of the result we have. And in the case of a characterization of inactive carrier, the infecting genotype, the age of the carrier, and in our experience, the country of origin may influence the value of S antigen, determining higher level even in inactive carrier, probably because of different aspects of the natural history. What about new markers that are still under clinical validation? Well, recent reports suggest that detection and monitoring of HBV RNA could be useful to characterize patients at baseline or eventually the different kinetics during NUCs or PEG interferon treated patients could help to monitor the outcome of therapy. More data are available, mainly from Asian country, on the quantitation of HPV core-related antigen. By this antigen, core antigen, E antigen, and P22C are detected, and preliminary data suggest a possible role in the prediction of risk of extracellular carcinoma, possible marker of safe lamivudine discontinuation, and marker to monitor our patients in treatment. The interesting point is that indeed the level of these antigens decline from the immunotolerance phase to the inactive phase. Thus, indeed, there is a correlation with the different phases of infection, and also this study from Japan show a correlation with cccDNA. Thus, this assay, I think, is interesting, and but in any case, require further clinical validation to better understand how to correctly use in clinical practice. But what about the host immune, the study and the monitoring of the host immune response? Well, Professor Ferrari show, and his group show, as indeed in the different phases of infection and disease, we have a different pattern of T-cell HPV-specific response, and the highest response being observed in those carriers who the spontaneous resolution of the infection, but also in patients who clear as antigen during NUC treatment or interferon. Thus, indeed, studying the T-cell HPV T-cell specific response could help us to characterize our patient. However, at the moment, this assay cannot be used in clinical practice because they are quite complex and expensive. More recently, always Carlo and his group show as studying the NK phenotype could be useful to monitor antiviral NUC therapy, particularly during NUC therapy, patients show a transition from the inflammatory phenotype, NK phenotype, to a more quiescent profile, and in the future they hypothesized that studying the NK phenotype could be a way to classify the response to NUCs and classify carriers who achieve control as compared to those who didn't, mainly because this NK cell phenotype correlate with the HBV-specific T-cell response. Finally, we already start to talk about the quantitative measurement of anti-HBC response, and some data, preliminary data suggest that the level of anticore correlate with disease activity. In fact, lower level are observed in E-positive patient in the immunotolerance, low level are observed, sorry, in immune inactive carrier as compared to patients with chronic hepatitis or patients who respond to antiviral therapy. So indeed, the level of this antibody appears to correlate with the extent of liver disease and immune activation. Other data suggest a possible role in the stratification of the patient at baseline before antiviral therapy, and for instance, in E-positive patients, having high level of anticore at baseline could identify E-positive patients in the immunoclearance phase, patients who are more prone to respond to interferon or NUCs therapy. Finally, what about the possibility to study the interplay between virus and host? Well, in the recent year, we look at the microRNA profiling, as microRNA are the translational regulatory elements that modulate the expression of cell genes, and we know that during infection we may have a changing of this profile in mRNA profiling. Furthermore, we show as in S particle carry specific microRNA. Briefly, we were able to identify 6 mRNA, able to define a score that in our cohort, that's this score should be validated in external cohort, so I have to underline that is really in-house study. The score, that we identify by using this MIRB index, were able to identify inactive carrier with high diagnostic performance. But even more interestingly, patients with disease treated effectively with PEG or NUCs develop MIRB index similar to inactive carrier. As you can see here, these are the baseline value in our chronic hepatitis B patient. Those who achieve a response, a sustained virological response with interferon, develop after 6 months after the end of therapy values similar to inactive carrier. Well, we further analyzed the kinetics of this MIRB index during interferon, and as you can see here, the profile of MIRB index are different in responder as compared to non-responder and relapser in E-positive, but also in E-negative carrier. And particularly, we were able to define a threshold that from this preliminary data would be able to identify at the end of 1 year of interferon treatment those patients who will maintain the response to interferon as compared to those who will relapse. This was shown in E-negative carrier, and we know that we are at the moment missing a consistent diagnostic tool to identify sustained virological responder. Finally, we also analyzed a cohort of over 160 NUCs-treated patients, and interestingly, as you can see here, the value of MIRB index changed significantly, improving during NUCs therapy, and after 4 to 5 years of treatment, more than 60% of our carrier had value comparable to those of inactive carrier. And interestingly, most of these carrier patients who changed their MIRB index value had low level of S antigen, indeed suggesting that the variation of MIRB index correlate with the decline of S antigen, and we may hypothesize that during NUCs therapy, this is a hallmark of immune control achievement. Thus, in conclusion, for HPV management, we are moving from a quite simple dashboard where we were using just a few markers to a more complex one where several different markers can be used to study to characterize the viral infection, the host immune response, and the interplay. But all these markers that apparently make more complex our job in clinical practice has just to be used as the different tools a tailor will use to prepare the right suit for his client. So I hope this will help us to optimize the antiviral, the management and the antiviral treatment of our HPV carrier. Thank you for the attention.
Thank you very much, Professor Burnett, for the very excellent overview on this topic. It's a very difficult topic. In the interest of time, I'm afraid we don't have any time to actually have questions, and we would like to thank you again